Hi, everybody. I'm Steve Cohen, the EMS training specialist for Whatcom County, and we've been talking about in the education committee about the new trauma team activation at PeaceHealth. And the one person who could tell us all about it is Becky. And Becky, welcome. Everybody knows who Becky is. So welcome to this quick educational program on PeaceHealth trauma team activation. Good to see you.
All right. Thank you, Steve. I can tell that you have a podcaster background. You're a natural.
Oh, well, thank
Um,
you.
okay, so this will be relatively quick, but we updated our trauma team activation criteria in response to updated guidelines from the Department of Health that came out in December of 2024. So depending on when you're viewing this, it is important to make sure that you have the most updated set of trauma team activation guidelines because we do update them periodically. So this is as of April 2nd, 2025. And so trauma team activations, we have two levels of activation at St. Joe's, which is consistent with what most trauma centers have. The full trauma team activation, I'll get into who responds to that. But the difference in whether we call a full activation or a modified, or what we call in the ED a standby activation, really has to do with the patient condition. So for a full trauma team activation, it tends to be based on the patient's physiologic or anatomic condition, along with a mechanism of injury. So if they're having compromise with airway breathing, circulation, if they have a neurologic deficit, or certainly if there's penetrating injury to the head, neck, torso, or groin. And then another one is a suspected spinal cord injury. I'm going to go through all of the criteria in detail, but these are just some examples of the kinds of findings that would lead to a full trauma team activation. Mechanism of injury tends to be more leading to a modified or standby trauma activation unless the patient is compromised. But if they have clear signs of injury and any of the mechanisms of injury that we have listed in our criteria, they have a high risk of serious injury that maybe just hasn't declared itself yet. So some good examples of that are high-risk motor vehicle collisions or motorcycle collisions, pedestrians or riders who are thrown with significant impact, significant blunt trauma, or falls with suspected serious injury. Okay, so for a full trauma team activation, which you might hear called a trauma response in our hospital, these are the team members that will arrive to the ED, usually within minutes of paging out the trauma team activation. By DOH guidelines, the trauma surgeon must be at the bedside within 15 minutes of being notified. The only exception to that is if the trauma surgeon is encumbered in a surgical procedure, then we call in a backup surgeon and they have 30 minutes to get to the bedside. So these are the official criteria for a full trauma team activation. As I said before, it's primarily called for physiologic or anatomic compromise. Um, so a patient who has clear signs of traumatic injury, who is actively unstable. So we have blood pressure criteria for adults, blood pressure of less than 90 at any time, or for patients who are older than 65 years old, the blood pressure criteria is 100. That's a change. It used to be for all adults, the criteria was a systolic less than 90. And so now we've added criteria for injured older adults that really is systolic blood pressure of less than 100 we consider serious. Another way to look at it is if you see a patient with traumatic injury who has a shock index of greater than 1, which is where their heart rate is greater than their systolic blood pressure, then you want to think seriously about whether they might need a full trauma team activation and convey that information to the ED charge nurse. For children, the blood pressure criteria is still the same, less than 70 plus the age times 2. But we also added some descriptions of signs for poor perfusion in children. And that's because a lower systolic blood pressure in a child is really one of the late signs. So we want to be thinking about perfusion in children. Compromised airway and ventilation requiring assistance with intubation or bag valve mask. That's always been one of our criteria, but we've now added unresolved hypoxia with a SAT of less than 90%. With respiratory distress, defined by a respiratory rate of less than 10 or greater than 29 for adult patients. Glasgow coma scale, so neurologic compromise with a GCS of less than 9 or AVPU equal to P with evidence of significant trauma. Again, that's not a new criteria. That's always been there. Other criteria that have always been there: obvious evisceration, major vascular injury with active hemorrhage, amputation above the wrist or the ankle, a penetrating injury to head, neck, chest, abdomen, back, or groin, blast injuries with penetrating or significant projectile force, again, to those critical areas. Patients transferring from other hospitals who are receiving blood products to maintain their vital signs, or suspected spinal cord injury, which would be a patient with a significant mechanism of injury and motor or sensory deficits. And so the new criteria are this systolic blood pressure for elderly patients, the signs of poor perfusion for children, and unresolved hypoxia with respiratory distress. And so for a modified or a standby trauma team activation, these again are primarily called for mechanism of injury with potential for a serious injury. So we haven't really done the workup. We haven't done imaging. Maybe they're presenting with stable vital signs, but they have a very significant mechanism of injury. So we're concerned that there may be injury that we just haven't discovered yet. The responders for a modified trauma team activation include an ED physician, an ED nurse, an ED tech, and a respiratory therapist. And sometimes lab will respond, or sometimes the ED nurse will be drawing labs. A modified activation will get expedited imaging and workup. The ED physician has to be at the bedside within 15 minutes. And the goal is for us to get imaging within 60 minutes. And so what we're looking at for a modified is if they have a compromised GCS, but it's not less than 9, crush injuries involving the pelvis, torso, or extremities, suspicion of unstable pelvic fracture or long bone fracture. These are both pretty serious, and depending on clinical judgment, they may even warrant an upgrade to a full trauma team activation. Another thing to think about is there a high likelihood that we will need a trauma surgeon for this patient? That's a good reason to use clinical judgment and upgrade to a full trauma activation. One of our most common presenting mechanisms is patients who are on anticoagulation or platelet inhibitors who have any serious blunt injury or loss of consciousness after a traumatic injury. So mental status changes or loss of consciousness, direct impact to the head, neck, or the chest also. We see these patients a lot of times with serious rib fractures and then hemo or pneumothorax. And really, if you suspect any sort of serious injury, we've also seen C-spine injuries on elderly patients on anticoagulation, and we've seen pelvic injuries. So have a relatively low threshold for recommending that we at least do a modified for these patients. And then we have our falls category. So for adults, it's greater than 20 feet. For children, it's 2 times their height. And again, there's room there for clinical judgment, any fall with suspected serious injury in your elderly population. For motor vehicle collisions, a rollover or death of the same car occupant. Also vehicle compartment intrusion. So on the occupant side, if it's more than 12 inches or more than 18 inches on any side of the car. Extrication more than 20 minutes for a motor vehicle, or ejection. Those would all, we would want to do at least a modified trauma activation. And again, clinical judgment, if the patient maybe doesn't exactly meet criteria for a full trauma, but they really don't look good, or it looks like a very, very serious mechanism, those are good recommendations to pass along to the charge nurse for maybe an upgrade. Riders who are separated from a transport vehicle or even a horse, they may warrant a modified trauma activation. And also pedestrians who are thrown, run over, or have significant impact. And that goes for bicycle riders too, who may be impacted by a motor vehicle. And then here's a nice broad one: blunt trauma with injury caused by forceful, heavy, or high-speed impact. I mean, this goes to those patients who maybe have a big tree branch fall on them, or some of the industrial accidents where perhaps something fell from a high shelf at a Costco and hit somebody in the chest. Those are good reasons for us to expedite imaging and do a modified trauma. Burn patients, little bit of a judgment call, but any serious burns, we want to do a modified trauma. And generally, any serious burn is going to wind up getting transferred to our local burn center at Harborview. And then the last category here, strangulation or near drowning. If there's no other signs of trauma, we often don't need a trauma surgeon. But we do want to use that physiologic activation criteria to determine the trauma response level. So if they are seriously compromised neurologically or respiratory or blood pressure, we would still upgrade them to a full trauma and do that full evaluation. And then we have at the top of our trauma activation sheet, we do list these comorbid factors as other possible triggers to either call an activation or increase the activation level. So trauma with a patient who has significant medical comorbidities, people at the, distant age spectrum, like younger than 15 or greater than 65. These are clinical judgment calls, but we want you to consider them when we're thinking, does this patient need more of a trauma activation? Exposure to extreme heat or cold. We've had some hypothermia patients lately who have needed a lot of resuscitation. Patients who are decompensating seem to be just getting worse and worse on the way to the ED. Pregnant patients of 20 weeks or more, we would want to at least do a modified trauma activation with any kind of trauma mechanism. And then here's that clinical judgment again. We want to remind people we would rather overcall trauma activations than undercall. So we're much more concerned about under triage in this population. And then just a final quick little summary. This last year, we had over 3,000 patients who are entered into our trauma registry. Patients who get entered into the trauma registry are any patients who have a trauma activation or who are admitted to the hospital or transferred to another level of care or transferred to us from another level of care. About half of those patients wind up getting admitted to our hospital. Ground level falls in all of the 3,000 patients make up about 50% of our trauma volume. And certainly not all of them get admitted, but they have the potential for serious injury. Our overall trauma mortality is the best in the state. It's less than 2%. We actually have very good comparative indicators for our trauma outcomes. And then the next two most frequent mechanisms of injury, not surprisingly, are motor vehicle collisions and bicycle-related injuries, which is unusual for most trauma centers to have bicycles be such a high category of the mechanism, but not so surprising if you look at Whatcom County and all the bike activity that we have here. So that's what I have to share with you. If you have any questions, please feel free to reach out to either me or Robin Stymack, our trauma nurse coordinator, and we'd be happy to go over the criteria in greater detail. We have distributed copies of the criteria, so you should have those available at your stations or through your leadership. Any questions, Steve?
Couple questions for you, Becky. One is, when you talk about strangulation, does that also include hanging?
Yeah, that's exactly what that is. Yeah.
And the other question is what can we do to make the process a little bit easier for notification, or what can we do as an EMS system to make it, I guess, flow freely for you when we call in with a trauma call?
Yeah, that's a great question. Thanks, Steve. Being aware of these criteria and exactly why you have concerns for the patient and relaying that clearly to the charge nurse is extremely helpful. Because you're right there with the patient, you have eyes on the patient. So telling the charge nurse what you're seeing really helps them make a decision about the triage level and the urgency of that patient. So that, I mean, that's probably one of the most important things in terms of getting the patient worked up and the appropriate level of care as fast as possible.
Becky, this was fantastic. I appreciate you spending a little bit of time with our system and going over this criteria with our system and with our providers. It's very much appreciated. So thanks a lot, Becky.
Happy to do so, and feel free to reach out with any questions. Thank you.